It's an honor to be invited to talk to this wonderful group, and I'd like to talk about the many things that affect the skeleton in Loeys-Dietz syndrome, specifically the strength of the bone, the recognition through the skeleton, and the effects on the hands, feet, spine, and even broken bones, all to deal with Loeys-Dietz syndrome. One of the things that really gets people's attention is knowing whether the bone density in Loeys-Dietz syndrome is strong enough to support the spine and whether there's an increased risk of fracture in this syndrome. So we tried to answer that question by surveying and canvassing the broadest number of patients with Loeys-Dietz syndrome that we had using the Hopkins database and also the foundation, trying to find out whether there was an increased risk of fractures and whether it correlates with the mutation. And we were able to look at 57 patients who had Loeys-Dietz syndrome, and more than half of them had experienced more than one fracture, and 3 people had even experienced as many as 4 fractures. And these were equally distributed between the upper and lower extremities, and even a few people had had spinal fractures. And if we looked at the cumulative risk of having a fracture by age, by the late adolescence, as many as half of patients with Loeys-Dietz syndrome, at least to the respondents, had experienced at least one fracture. And this is significantly increased from the normal population, in which almost half that number of persons is expected to experience a fracture by adulthood. The distribution between the mutation types is approximately equal. Well, why is that? We looked at the ultrastructure of the bone in micro-CT, looking at normal human bone and also Loeys-Dietz bone. And you can see in the micro-CT, comparing the two images, there's a significant decrease in the number of bone trabeculi, in other words, the lattice work of the bones, and also the connectedness of those trabeculi. So there is some problem with the formation and the connectedness of these bones, and we're trying to understand why that is. Looking at the ultrastructure of the bone, osteoclasts are the cells that remodel and weave the bone together, and osteoblasts are the cells that build up the bone. And we can see that in Loeys-Dietz syndrome, the way that bone is made and remodeled seems to be altered and perhaps uncoupled so that you don't get the normal formation and remodeling and weaving of the bone that makes it stronger. Looking at micro-CT and mouse model of Loeys-Dietz syndrome, you can see that there is also a decreased formation of the cortex of the bone and also the number of bone of cells making up the trabeculae, comparing the mouse control on the left, that is the non-Loeys-Dietz mouse, and the Loeys-Dietz mouse on the right. Again, you can see some decrease in the outer shell of the bone. Loeys-Dietz syndrome is typically recognized through some of the internal features as well as the external features, but the bone and muscle findings are common and sometimes represent a way that the syndrome is diagnosed. The skeletal features are the ones that are visible, and these allow many patients to be recognized, and there are some patients who have come to an orthopedic clinic and been recognized as having Loeys-Dietz syndrome where they weren't picked up by the pediatrician or by the hospital, and so this allows for appropriate imaging, maybe genetic testing, and ideal management of the vascular and internal findings and appropriate counseling. We studied 65 patients with Loeys-Dietz syndrome looking at the skeletal features, and in 16 of these patients, previous diagnosis of Marfan syndrome had been made. 2 others were diagnosed as Ehlers-Danlos, and 1 a related connective tissue syndrome called Sprinson-Goldberg syndrome. So there are many other ways that persons are misdiagnosed, and perhaps the management is not as ideal when it's an incorrect diagnosis. In the upper extremity, many patients have long, slender fingers, thumb and wrist sign, where the thumb and wrist can be either wrapped around or protruded through the palm. Camptodactyly is a name for fingers that can't straighten out at the joints, and 3 patients even had surgery for that. In the hip, there's a slight increased risk of hip dysplasia, which is an abnormal sloping of the hip socket, and there seems to be an increased risk of deepening the hip socket or protrusion although a rare need for hip replacement. Here's an example of how the hip can evolve from a normal on the left to a deepening of the hip socket on the right, even over the course of 4 years. And if you look at especially the thickness between the inner ball and the pelvis itself, the bone has become thinned and the socket has been deepened. And this is something that you don't typically see in other syndromes. So we're trying to understand the mechanisms for this remodeling and this deepening or wear of the hip socket, even in a young child. In the lower extremity, there's often an abnormal shape to the joints. Valgus means bowing inward, and especially in the knee, you can have knock knee. And this is usually not a problem if it's mild, but if it's severe, it can affect the efficiency of walking or even cause pain in the knees. And sometimes there's a way to correct that by guiding the growth straight by using a small plate on the inside of the knee, as you can see here, causing the knee to straighten out over time. A bigger problem, and not really solved yet, is the looseness of the connective tissue. There can be side to side or medial to lateral laxity. There can be hyperextension or bending backwards, as you can see in the lower picture here. And there can be weakness in the muscles around the knee. And this is even more of a problem and more limiting if the foot and ankle are also loose. The treatment is still not ideal. Ligament surgery can sometimes help people, but it generally tends to stretch out because the same tissue is used to replace it or will remodel into that tissue. There can be sometimes a role for bracing, but bracing is not ideal in the knee because it's cumbersome. But you can at least remodel the bones if the bone structure is out of alignment. The foot is also affected in Loeys-Dietz, but different in almost every person. The hind foot or the back of the foot is often shifted out to the side. Again, the term valgus is used here, and you can see in this picture here the dimpling on the outside of the foot, which is a sign that the bone of the calcaneus is shifted out to the side. And this can lead to a dropping of the arch or a flat foot. On the other hand, some patients have club feet, which is an inward turning foot, and this is often seen at birth. This is often treated by casting and bracing. We don't know why about 20% of Loeys-Dietz syndrome patients get club feet, and we don't know why contractures and laxity coexist. It's really a paradox. Why will the foot be so stiff and turned in some joints, but the knee will bend backwards and exhibit the opposite tendency of laxity? So this is something we still need to understand, why the connective tissues behave differently in each joint. The treatment of club feet is typically stretching out with casts. We try to do this from early onset and then brace the feet afterwards. We try to avoid surgery if possible, because if surgery is done, sometimes the foot will overcorrect and shift into valgus, as you can see here. This person had surgery on the club feet, and as you can see, to a certain extent, the foot is overcorrected and gone into valgus. So the connective tissues cannot be controlled, and oftentimes surgery results in a shift dramatically to the opposite side. Sometimes there's a bending inward of the middle of the foot called metatarsus adductus, where the foot's curved inward. And this is seen in most Loeys-Dietz patients to some degree. The treatment is usually conservative, stretching and watching. Sometimes special shoes are needed. And only in rare cases, if it's a problem with fitting into shoes, can an osteotomy or realignment of the bone be done. Another condition is called skew foot, in which the front of the foot is in and the back of the foot is out. And this is common in Loeys-Dietz syndrome, sometimes after surgery for club foot, as we just saw, but sometimes it's just the way the foot grows spontaneously. If it's mild, it can be left alone or should be left alone. If it's severe, however, you can lengthen the middle bone of the foot and slide the calcaneus back over with surgical correction. Flat foot is very common in Loeys-Dietz syndrome because of the laxity or looseness of the connective tissues, and it's pretty well established that braces do not reshape the foot. They don't cause the foot to grow back into place. And they may even cause pain because they cause pressure where the foot just wants to be left alone. My practice is not to use a brace prophylactically, because you can't really change the foot or make it grow differently. In some cases, there may be a limited role for surgery if the foot is symptomatic, if it's painful, if there's callus forming on the inside of the foot, in which case you can do an osteotomy or realigning of the back of the heel and lengthening of the side of the foot to recreate a normal shape, as shown here. Work on the bones is usually fairly predictable, but work on the ligaments and the tendons is more prone to stretching out. A calcaneal osteotomy is a shifting of the bone that allows the pressure to be distributed back to the center, and the foot can straighten out, and the weight is evenly distributed on the back and the front of the foot. Other features in the skeleton can include the sternum and the ribs. The pectus deformity can either go in or go out, or sometimes be asymmetrical from the right to the left side. Pectus carinatum is seen in a minority of patients, and an excavatum, shown here, is more common, although it varies in severity. Here are some CT scans which can be used to quantitate and analyze the pectus. And you can see that in the person on your left, the sternum goes in, and it's asymmetrical between the right and the left side. In the person on your right, the sternum is more outwardly shaped, or carinatum, and that is something that in some cases can be treated surgically, but in many cases is treated just by observation and tends to be less noticeable as you get older. One of the biggest and most important areas is the cervical spine. And there are many findings that are just curiosities, but also some that are physically important and neurologically important. Over half the patients have an abnormal formation of the cervical spine, and it seems to be correlated with other midline defects such as the soft palate and the other cranial midline defects. Here are some examples of CT scans. As you can see here, this person has a missing arch of C1, which is actually pretty stable. Here's another person with the same thing. And in other patients, the odontoid, which should be right in the center, is off to the side of C1, as well as an arch in the back of the neck. The C1 posterior arch is also bifid. So these are findings that are important if surgery is undertaken, but not necessarily findings that you will notice unless you've gotten a CT scan. Here's another example of the odontoid being off-center. It's not really a problem, it's more of a curiosity. But why does this happen? We don't really understand why these asymmetries happen in Loeys-Dietz syndrome. Subluxation refers to bones shifting or being off-center, and this can happen at any level of the cervical spine, C1, 2, 2, 3, and even 3, 4. And here are various examples of the neck tilting forward to a mild degree or a moderate degree or an even more severe degree, in which case it can cause pressure on the spinal cord and may occasionally require surgery. If it's mild, we simply monitor it over time, especially during growth. Growth is a time when things are changing. A lot of pressure is exerted on the spine during growth, and so you have to monitor things more carefully. If there's an abnormal movement in the spine, then that needs to be followed with yearly or every other year x-rays. In the lower spine, sometimes the spinal curvature can develop. A brace does not usually stop worsening of the curve, but it may slow it, and in some cases it's worth trying. We don't know what the success rate of bracing in Loeys-Dietz syndrome is because there's too little data on that, but from Marfan syndrome, a reasonable surrogate for Loeys-Dietz syndrome, it doesn't seem to have as much success, and we use it early if at all. It's useful for flexible curves in the 20 to 40 degree range, but not for the more severe curves, in which case it won't really help. Scoliosis is present in about half of Loeys-Dietz syndrome patients, but it's usually moderate in that 20 to 30 degree range. But some patients have had surgery, as you can see here, and sometimes the cervical spine abuts up against neck instability, and the junction can cause problems and may require surgery to straighten that out as well. And this can vary with age. As the patients get older and growth happens, the risk of scoliosis increases. And typically, if the curve is over 50 to 60 degrees, we will recommend surgery to prevent later problems and more severe difficulties later on down the road. If the curve becomes severe at an early age, we still want you to grow, and we want to maximize your proportions, maximize the space for the lungs, maximize the space for the abdomen, and so we will sometimes do what's called a growing rod, which is a rod which can be elongated about once a year to help the trunk grow and remain straight. And this is seen in a minority of Loeys-Dietz syndrome patients as well. If the curve can be monitored until adolescence, then just one surgery can be done. But if it's severe early on, then growing rods are treated. Later on in life, there seems to be a slight increased risk of disc degeneration and bone spur formation. And so this can cause pain in some patients, but it's variable. Another finding in the lower spine is abnormalities of the spinal dura or covering. Duralactasia is seen in about 2/3 of Loeys-Dietz syndrome patients, similar to Marfan patients, and is a reflection of the weakness in this normally tough structure as gravity increases the pressure distally. In the lowest part of the spine, the junction between the lumbar spine and the sacrum, there can be a slippage of that lowest vertebra called spondylolisthesis, and it could even almost fall off the sacrum, as you can see here, and in which case needs to be stabilized surgically, as shown in this image here. And sometimes the patients may need to have spanning of the majority of their spine, or sometimes the whole spine if abnormalities occur from top to bottom, and occasionally you will see somebody who needs the entire spine stabilized because of different findings over time. Fractures or broken bones can happen in Loeys-Dietz syndrome, sometimes without really much notice. This person had a fracture from a mechanism she can't even remember, but just started to limp, and this was a stress fracture of the femoral neck, which could become quite severe, but fortunately kind of healed itself before it became all the way off. So in summary, Loeys-Dietz syndrome produces many different findings throughout the skeleton, from the face to the neck, to the lower spine, to the limbs and the feet. It's sometimes thought as Marfan syndrome with club feet. It's sometimes recognized by its unusual neck instability and its formation of midline defects. It's sometimes recognized by the contractures of the fingers. And the ligamentous laxity is much more of a problem in Loeys-Dietz syndrome than it is in Marfan syndrome, and it's something that we really would like to and need to find a solution for. And it's also pleomorphic. In other words, every person is different from every other person with Loeys-Dietz syndrome because of interactions between genes, we feel. So a lot of research is needed in this condition. We've identified some of the problems and prioritized some of the problems. We hope to be able to find ways to strengthen bone, prevent fractures, as well as prevent the need for more serious surgery as time goes on. So I think it's important to anticipate osteopenia, to look at the whole spine from the neck to the lower spine. If surgery is done, you have to watch for problems at the edge of the surgical correction, whether it's the foot or the spine. And we would like to try to make this information more available to orthopedic surgeons throughout the country and the world who are just starting to learn about Loeys-Dietz syndrome. But it's a very fascinating and serious syndrome for us to learn about, and we hope to disseminate this knowledge and have more defined principles in management in the future.